if you want. Okay, great. So welcome everybody. As I mentioned, tonight's webinar is Understanding Home Care Options. My name is Adina Siegel. I'm the Jewish Community Outreach Social Worker at CaringKind. I want to make sure everybody understands this is an overview of all of the home care options that are available in New York City. I will be providing information for the other workshops that we have that provide more of like an in-depth kind of how do you go about getting mostly Medicaid for home care. But I do think it's important for everybody to be aware that there are a lot of different ways to get home care. And many different considerations. And so this is going to be the overview for tonight. For our agenda, we're going to be looking at what is home care? How do I know when I need it? Or how do I know when my person needs it? A look at the different types of home care. We're going to talk about respite care, private pay, long-term care policy considerations. Some people might be having some long-term care policies. It's important to just be educated about what to know about. We're going to talk about Medicare and Medicaid, and I'm also going to touch on what happens if you need more hours from Medicaid in particular. And these slides will be shared at the end, at post presentation, absolutely. So in general, when we're talking about home care, we're talking about services that provide the necessary care to maintain independence at home. It can really run the gamut from, helping with shopping, cooking, housekeeping, things that are kind of away from personal care and more around home upkeep, to assisting with personal care. I mean, it can be pretty intimate, such as showering, toileting, assisting with ambulation, if somebody is bedbound, even just in terms of turning, can also be part of home care if a person is home. So how do I know when I need home care? It's an important question, and there are a whole bunch of considerations to think about. I think the first and foremost, you really want to think about the person's ability to keep up with their own activities of daily living, right? Are they able to keep a schedule up with their eating? Are they eating 3 times a day? Are they able to keep up with their medications? Are they keeping up with their hygiene? Do they need assistance with things like laundry or shopping? These are all things to keep in mind. A person's safety is also a big consideration. Is a person safe being home alone without anybody there? Is there a fall risk? Is there a wandering risk? These are all things that also should be taken into account when thinking about the need for home care. And another really important need, and I don't think that people tend to think about this or give it as much importance as I do, excuse me, and my colleagues, but the caregiver's ability is also really important. It might feel, as a caregiver, you might feel like you want to do everything yourself. You know the best way of doing things. At the same time, not every caregiver has the ability to do everything. I think most caregivers actually don't. Eventually, caregiver burnout does creep in because one person really can't do all of this care, especially as needs progress. Caregivers do need a break, and that is a very legitimate reason for caregivers to get home care. And so that is another very important consideration. A person's openness to receiving assistance. I mean, sometimes you really, you might be a caregiver caring for someone you really want to get home care in, and the person is consistently refusing, and they have the capacity to continue to refuse. That becomes that's kind of a whole other topic and a whole other workshop. I do want to acknowledge that does happen. But then there are different degrees. How open is the person to receiving assistance? Maybe they are not comfortable having somebody helping them in the shower, but maybe they're comfortable having somebody do their laundry or go shopping for them or run errands, and that maybe gradually they can be introduced to getting more care as trust is gained with the person who's helping them. And then there's the other consideration is future need. I mean, as long as a person is open to at least a little bit, you might want to consider having them be open to having some care, even if they don't necessarily need a lot of it. Maybe like if somebody is like early on in their diagnosis, having them have somebody come in once or twice a week to help with cooking, dishes, laundry, shopping, etc. But more errand-based kind of things will, might help to get them acclimated to the idea of home care, so that this way it's not going to be that, as the disease progresses and there become things that happen that are more urgent, and there's an urgent need for them to get 12 to 24 hours of home care in place, they're not going from 0 to 12 hours overnight after a major hospitalization or rehab stay. There is something to consider with, just in terms of future need and how we want to prepare for that, and maybe getting some help in earlier is a better way of handling it for that particular person. Now, there are many different, well, not many, I have 3 here, but there are 3 major different types of home care or avenues to get home care. The quickest one and the simplest one, I guess, is private pay. And there are a couple of different places you can go for that. At CaringKind, we have a website. It's called togetherwecare.com. It's sort of like a match.com for home health aides. We have a home health aide training here, where it's a 6-week training for home health aides to really get an understanding of dementia and how to care for somebody with dementia. Once those aides graduate that program, they are able to put a profile up on togetherwecare.com. As families, you can put a profile for togetherwecare.com, and you can, go online, see who's there, see where, if there's a person who is in your area or who, looks like they would be a good fit, and see about organizing something that way. It's a completely private arrangement. We actually do not have anything to do with the arrangement part. It's really just a service of providing the information about who actually has taken our training, and giving them opportunities to promote themselves. So just I want to keep that in mind. But we do have that option. There are home care agencies that provide private care. Word of mouth is another way. A lot of people find aides, asking friends or family members, acquaintances, people in places of worship or other, social clubs may know, or even doctors may know of good aides that are private, are private. Another avenue for home care that may not be well known is through Department for the Aging in New York City. Every office on aging throughout the country should be able to offer at least some form of this, but I'm talking about New York City right here. And there's a program called Expanded In-Home Services for the Elderly. I'll go into this a bit more in depth in a later slide, but that provides some small amounts of care for people living at home, to try to help them stay independent. There's also caregiver respite program, and that's actually not focused on the person or the client. It's focused on the caregiver, and that is also designed to provide a short-term break. And lastly, there's Medicaid, and Medicaid has 3 different plans. Medicare does provide very short-term. I will talk about that briefly, but it's not really very significant for this discussion. Medicaid is really provides the long-term coverage. The most common form of Medicaid that people get when it comes to long-term care is what's called the Managed Long-Term Care, or MLTC program. That's their I guess the way they do their personal assistance program. There is also an option to be able to have your own aide who you decide. That's called the Consumer Directed Personal Assistance Program, otherwise known as CDPAP. I've sometimes seen it called CDPAS as well. I'm not sure what the S stands for. And then there's the Nursing Home Diversion and Transition Program, which I will talk about all of these in much more depth. So when it comes to private pay, there's a lot more flexibility. There's a lot more accountability. That person is accountable to you. They're not accountable to a third-party payer. The major cons, though, is that they're very costly. Right now, they're really, you can expect to pay, 25 is pretty low. It's closer to like $30, $32 an hour, may even be a little bit higher depending on the agency. If you decide to have your own aide that you contract with, you may not have coverage if you're not using an agency. If that person is sick, if that person's going on vacation, it's really on you to be able to find someone who's going to cover. And the aide has more discretion on what they will or will not do. There's no way that you can get, unless they're with an agency, if it's a private arrangement, that aide, you can't compel the aide to do something that, if they really don't want to do it, you can't say, well, your agency has this policy. You can't use that. If you do private pay through an agency, an important consideration to know is that agencies are prohibited from doing any activities that are considered medical. So even something like administering medications, if you have an aide from an agency, even if it's private pay, they will not be able to administer medications. They can, give medication reminders. They might be able to, I'm not even sure if they're able to like bring the pill box over, but the person, they can observe the person taking their medication. They cannot have anything to do with the person actually, giving the person their medication. They're not, and if there are more intense needs, they're not going to be able to assist with tube feeding, catheters, anything of that intensity. They're not going to be able to do. Okay, I'm going to, I got a question here, but let me first just finish this. There are private duty nurses, that's a separate service, and they're able to provide this service. But but they are not able to, hold on, but they are a separate service, and it's a different discussion. And somebody just asked it with private pay, you have to account for income, Social Security, or other taxes. Yes, that is something that is taxable. And, obviously you might want to discuss this with your accountant or anything like that, because these are all things that are required with a private pay arrangement. With a home, if you do it through an agency, then, it's done through the agency. They are, it's factored in, all of the payroll stuff is factored in with the agency. With your own, you're the one who's responsible for ultimately doing that. Okay. Now, through Department for the Aging, you have, as I mentioned, the ISEP program. So that's the expanded in-home services for the elderly. This was really meant to provide home care services for people who make above the Medicaid limit, but they are not wealthy enough or don't have enough money to really get home care. It is provided through case management, Meals on Wheels. If a person is receiving Medicaid, they are not eligible for this program. I'm sorry, I hear some background. If everybody are muted, I may have to mute people. I'm sorry, I'm not good when I hear background noise when I'm on Zoom. I apologize. Okay. The ISEP program is provided through case management, Meals on Wheels program. You are not eligible if you're receiving Medicaid. As I mentioned, this is really meant for people who are making above the Medicaid limit. The recipient, whoever is receiving these services, they have to be considered self-directing and safe in their home. I'm sorry, I really very much need this to be muted. Thank you. So a person needs to be considered, needs to be safe and self-directing in their home, meaning that they, the aide is not going to, the aide has to be told what they're doing. The recipient really has to be able to tell the aide what to do, or at least be, train the aide into what to do. Hold on, I see I have, okay. Okay, great. I'm gonna, you know what? I'm gonna go through everything later in the chat. The one thing to know though, that there is a cost share to clients. It is usually subsidized for low income clients, but after after a certain amount of money, it's pretty much standard rate for home care. They do not provide more than 12 hours a week, so this is not meant for people who are going to need more oversight or where safety is a major concern. And the other thing to keep in mind is that there may be a waiting list, depending on the agency, depending on the time that you call in for services, you may have to wait. And we're talking about maybe a couple of weeks to a few months. With caregiver respite, that's a different program through Department for the Aging. That's designed to give a short-term break for the caregiver. So which means that a person needs to have an identified caregiver. family or friend, somebody who is non-paid, obviously. The amount of hours vary by each provider. It could be, maybe like twice a month, or it could be more than that. But it really depends. You would have to talk to the actual provider in your area about how much they're giving. You should be able to get both in-home care or congregant settings, like an adult day program that should be able to be provided through the Caregiver Respite Program. And ideally, and really what I guess the thinking is behind doing this is really to help when somebody is in the process for applying for Medicaid. It could take, about, 6 to 9 weeks to get Medicaid. So it really, sometimes more. So it can really be helpful to have a break during that time. So a lot of times it's a good option to be able to use the respite program, to fill in some gaps, while you're waiting for Medicaid to be approved. Another way that respite can be used is like if you're going on a vacation and you need coverage. If it's a short-term, identifiably short-term break that a caregiver needs, and that there is, a clear plan afterwards for the long-term care of the person, that's really where caregiver respite comes in. So there are a couple of other options for respite. Aside from Department for the Aging, there are other agencies that have grant programs that fund respite. For example, our agency, CaringKind, we do have a grant program to assist with short-term respite needs, and we're looking very similarly to what the Department for the Aging agencies are looking at, in terms of it, being short-term, having a beginning and an end, and having an after plan where the person has, is safe and has a regular care provision. And the other things to think about in terms of respite is that there are a lot of assisted living facilities which have respite programs. They're private pay, but they will take residents for a short-term stay. And nursing homes also can provide some respite depending on the Medicaid plan that the person has, unless we're talking about a private pay would be quite costly, but there are also those provisions in nursing homes as well. So in terms of long-term care policies vary by provider. It is incredibly important to read the fine print of the policies if you hold such a policy. Most policies have a 30 to 90-day deductible, also depending on the policy. And that means that you have to cover the cost of the first 30 to 90 days from the activation of that policy. And the long-term policy needs to be activated. Once you call them up, you say you want to activate it, then they come down to assess the holder if they qualify for services. Depending on the policy, it can cover home care, adult day programs, assisted living, nursing homes, geriatric care managers. Some policies actually do cover geriatric care managers. Geriatric care managers are professionals who are, I've heard people refer to them as rent-a-daughter, where they can come in, they can set up home care, they can set up other services, they can be the eyes and ears on that person, especially if if you're caregiving long distance and you're not able to be with your person, often, they can provide a regular oversight for that person in terms of overseeing their medical care, overseeing their home care, things like that. And long-term care policies, again, with the fine print, you have to realize it can be time limited. Sometimes they'll cover only a certain amount of time, like 3 years, or sometimes it'll be a monetary amount, like, $1 million. So, and then the long-term care policy runs out. So, and these terms vary based on whatever policy you're holding. Okay. So Medicare does not cover long-term care. I think if there's anything that you're going to come out of this with, it is really important to realize and to know Medicare does not cover long-term care. What Medicare does provide is home care after a hospitalization. A hospitalization is considered, it's usually more than 3 days. It's not considered observation, I believe, unless they changed it. Under 3 days is more considered observation. And so you don't usually qualify for home care after like a 1 or 2 night stay in a hospital. It usually has to be 3 days. In order to qualify for home care through Medicare, you need to have a qualifying skilled nursing need. So we're talking about something like wound care, if there's a physical, speech, or occupational therapy need. It's not going to happen, on its own, but you're going to need some other type of nursing need in order to qualify for home care. Medicare will cover up to 90 days of home care, but after hospitalization, but in general, they don't usually do a full 90 days. Patients will receive a few weeks of home care for about a few days a week of home care for about 2 to 3 weeks. I will say this, it is helpful to have a working relationship with your doctor. A lot of times doctors can find a qualifying need for the person to be able to get some home care. If, let's say, things are getting overwhelming and the caregiver does need a break, and, for whatever reason, there is no Medicaid application or other provision of care in place, it is helpful to be able to speak with your doctor and have them be able to advocate. Many of them do and will. So that is a very useful thing when it comes to Medicare. However, as I mentioned, Medicare is not something that you can bank on to cover home care in the long term. So Medicaid does cover long-term care. With Medicaid, there are income and asset limits. I think with income, it's like $875. Asset limits, I think they just raised it. I'm not sure what it is, but I think it's about 20,000 in liquid assets, give or take, because I don't know the hard and fast amount. One thing to be aware of, even if you make above or have above the income or asset limits, if you're an older adult who's over 65 and or a person with a qualifying illness, you can be eligible for Medicaid. When it comes to being over the income and asset limits, pooled income trusts and asset trusts can help with and can make you eligible. That is a pretty long discussion. We actually have some workshops on legal and financial issues and Medicaid home care. I'm going to put that information at the end, and I highly recommend that everybody attend if that is something of interest. As I mentioned, I'm just doing an overview of what's available. This is, something that's important to know, that even with significant, income and assets, there are ways to be eligible for Medicaid. So in terms of the way of Medicaid, there are several different programs that they have. You have, as I mentioned, managed long-term care is the most common one. This plan determines the plan itself. So managed long-term care it's overseen by some form of managed insurance company. They will go down and assess for hours, and they will provide home health aides through a home health agency. There needs to be some sort of demonstration of a medical need. So if it's somebody who just needs to be watched, they may be completely ambulatory, and let's say if it's just through I hate saying just dementia, but using their thinking, if it's just dementia, and let's say there is no other medical need, it might be difficult to get enough hours for that person. And not only that, it's hard in general to get 24-hour care. If people do get 24 hours through the MLTC program, it is not split shift. So in other words, you're not going to get somebody who's awake overnight. If it's 24 hours, the expectation is that that person will be able to sleep for 5 hours straight. In terms of the CDPAP program, a consumer directed program, it's the same idea as the managed long-term care program. It's actually the exact same application, except that you are going to be hiring and training your own aide. An aide can be a relative, but it cannot be a spouse or a parent of a dependent child. And when it comes to nursing home transition and diversion program, this is something not a lot of people necessarily know about. This is a Medicaid waiver program. And the whole idea is that it's going to divert people from going to a nursing home. And the thinking is, and rightfully so, it is cheaper to have somebody outside of a nursing home than in a nursing home. And so if it means to have somebody come and be awake, to ensure that person's safety, it's actually more cost effective. So if your person needs to have that overnight care, this is actually a good option, because through this option, you can have that split shift 24-hour care where there isn't that expectation that the aide is going to have any time to sleep during their shift. Okay, so if you need more, actually, you know what, I'm going to take this time to just look at the chat. I see I have 2 questions. Oh, thank you. Somebody was saying, actually, I have a few comments here. I'll just mention. Okay, somebody's from Search and Care, an agency on the Upper East Side in East Harlem, can arrange for ISIP and Meals on Wheels under Department for the Aging. So if somebody is, I will be giving the number just to access Department for the Aging services for every neighborhood and every borough. A lot of the Department for the Aging programs are based on community, different community districts and where you're living. So there's a central number to call to get information about your particular area. But thank you. And thank you, Marcy. I believe it's 16,800 for a single person and 21,000 or so for a couple in terms of the asset limit. So thank you for that update, because I still was with $15,000 for a single. So I appreciate that. And somebody mentioned that they're fighting for 24-hour care now. So this may be redundant for people who are actually trying to get 24-hour care. But there is a process if you do need more hours for Medicaid to be able to get it. And the way that would work is you're going to make what's called a service authorization request. This can be done at a 6-month in-home reassessment. For Medicaid, they have to reassess every 6 months. You can ask it then, but you don't have to wait. You can actually, ask anytime by providing a request via fax, email, or certified mail to member services or your care manager. All of that contact information should be in the member handbook under the utilization review section that they probably gave you when you first started with their service. You are going to want to provide a doctor's letter to show medical necessity, and you want to make sure to specify if it's urgent and needs to be expedited. I would say with everything, it's always a good idea to keep records of all your emails, fax confirmations, like any sort of communication regarding, your person's home care. Try to, keep records of it and have it on hand in case you need the documentation. So once you, ask for the service request, you will probably more often than not receive an initial adverse determination notice, which is basically the agency saying no. And they are going to be providing you with this in writing. There will be, different form you can send to request a plan appeal. You should request a plan appeal. After that, they will be providing you with a final adverse determination notice with information about requesting a fair hearing. Now, it's a long and frustrating process. However, if you get a fair hearing, it's actually a very good thing. Fair hearings have a very high success rate. So you do, and a lot of that is because it's not being determined by the insurance company, it's being determined by an administrative law judge. So, and they're much more likely to be, open to providing more services, because especially if you have the evidence to show the need. So it's really important to come prepared. Things you can use as evidence. You can have a written statement from the family caregiver. You can write you get a doctor's note. Even a home health aide statement is important. A physical therapist note. Any other provider's input. Any healthcare provider who is familiar with the case can be, providing something as evidence. As I mentioned, you're meeting before an administrative law judge. The judge is going to make an, determination after hearing both sides and study the evidence. They'll mail the decision, or you can access it online. And once you get that decision, you would have to you would want to make sure to notify your care manager as soon as you receive that information. I do want to say, I do want to say one more thing about this, and I will be providing this information in the end. There's a program called ICANN, which is Independent Consumer Advocacy Network. They are the ombudsman program for home care in New York State. And they are the ones who can also provide guidance and help with this process. So whenever I have people who are looking to ask for more hours or are looking to get a fair hearing, I will give their number and have them be in touch with them. So I will give that number it's in our resources slide at the end. That's also a very important resource for this. Another thing is that, so as I mentioned, the Nursing Home Transition and Diversion Program, the NHTD waiver. The NHTD waiver is another way to get more hours. And I actually have clients who do both. They'll do both trying to get the appeals process and apply for the NHTD at the same time. Both of these processes, take time, and between the two of them, something's going to happen first. And you can always decide to get, if the MLTC comes through and, you'd prefer with that, you can always just, not take the NHTD, or if the NHTD comes through, you don't have to continue with the MLTC. So it actually is beneficial to do both. And this is to obtain the NHTD services. These are the different contact numbers. There's the New York City region where you can contact it, and they have a particular office for Manhattan. They will do an initial assessment. The family chooses a provider, and the provider makes an assessment about hours of service. I do want to say, though, that it does take some time for the NHTD waiver program to get processed. And I've had clients lately, especially post-pandemic, this is anecdotal, but it could take like around 6 months, sometimes even 9 months. So it is a lengthy process. So it does sort of make sense to do both at the same time, so that this way you have some sort of coverage while you're waiting for the NHTD waiver to come through. So with that, that's kind of the overview. I do want to talk a bit about CaringKind and the work that we do. Does anybody have any questions that you want to mention or discuss that maybe I didn't touch on, or that can use a little bit of clarification before I talk about our program? You can either talk, you can either unmute or put it in the chat. Just want to make sure that that information is clear. Yeah. Okay, so I'll just continue with the CaringKind programs. So our helpline is really our first. Oh wait, I see a chat. Have I heard about an option for an external appeal versus a fair hearing? That's interesting. I actually have not heard about an external appeal, and I wonder who is doing that external appeal, or whether is it instead of a fair hearing?
Hi, sorry. This is Natalie. I just figured this might be easier. Can you hear me?
Yeah, absolutely, absolutely.
Okay, perfect. So actually, this came up today with a client of mine where she is in the appeal process as she's fighting for her husband who has dementia. She's just trying to fight for 24-hour care because there is a massive decline and he does wake up in the middle of the night. And unfortunately, they did provide a denial notice saying that he basically, instead of 7 days a week, 5 hours, they approved for an additional 2 hours. So essentially 7 days, 7 hours, which of course is not really, it's helpful in some, but it's not enough. Yeah. So she actually received a notice that mentioned the two, which is an external appeal and then the fair hearing. So I was a little bit taken aback by the wording and the phrasing between that. And even my supervisor was like, I haven't really heard of an external appeal before. But of course I just kind of did guide her to still do the fair hearing. But I was just kind of curious if anyone had also come up with that similar terminology, or if in the same sentence as a fair hearing, just because it's a bit strange. I've never heard that vocabulary before.
I haven't, I'll be honest. I mean, I wonder what the external is, unless that's another way of saying a fair hearing, but I don't know. I'm wondering if anybody in the audience is aware of this. No? Yeah, I don't know. I mean, I would continue to just go with what I know. You can also call up New York Legal Assistance Group. They do a lot of guidance around these matters. So or even ICANN might be a good resource as well, just to be able to provide guidance. in terms.
Yeah, that's what I've kind of urged her to do. So I'll just keep, urging her to follow through with ICANN or NILAG, essentially just for follow up and advocacy support in that regard. But yeah, that was very interesting wording on that notice. And I don't know if it's from the home care agency specifically, or if it's Medicaid, like, because it is part of a Medicaid plan, the MLTC.
Mhm.
So I'm just not sure if that was the home care agency's letter and their terminology, or if it's a little bit varied across different home cares. So just thought I would bring that up to see if anybody else had heard about that before.
That's interesting. No, and I haven't had clients, ask me about that or mention that if they are in that process. So I see, Marcy, I see your hand is up, and then I'm going to look at the chat.
Yes, I was just going to say that I have a client who, has come to the understanding that she may benefit from some home care. She was very adamant about not wanting something, wanting to get pushed into an HMO type situation. And I went online and I found that if you want home care and you want it for more, and the whole question of an MLTC, and I think she was having a lot of difficulty, well, not difficulty, but just very, very adamant about what she wanted and what she didn't want and be pushed into. She kept saying long-term care. But I found from looking on the Department of Health website that if you want home care for more than 120 days, you will have to enroll in an MLTC to be able to get the home care, let's say, for an extended period of time. So that was something that I found. I think she was more concerned about, being able to choose providers and things like that. But for more long-term, or, for going on and on, you would have to enroll in an MLTC. And of course, there are many, many MLTC programs, and there are certain times of the year where you can change, like an open enrollment period where you can change your MLTC. So those are just a couple of things. And NILAG's Evelyn Frank Legal Resources Program offers wonderful pro bono care. And Valerie Bogart she's an expert on Medicaid and presents, she offers different workshops. So I will sometimes refer people to NILAG if they need, if they're asking for legal help. They've got lawyers who are really, really excellent and know their stuff backwards and forwards.
Yeah, I second NILAG. They definitely are very, very helpful. And yeah, I mean, in order to get long-term care, it would have to be through an MLTC. And I do believe that it has changed that. I think there's like a 90-day waiting period between changing MLTCs at this point. So, I can hear that hesitation, but it should not impact her providers. If she does decide on an MLTC, I believe she should be able to still keep her doctors and things like that. I think the MLTC is strictly about home care.
I think there are some agencies, I think it depends. Some of the different plans have different types of plans that you can sign up for. Some are more, more restricted, I think, in terms of the networks of agencies that they work with and stuff like that. So that's, I think, what she was concerned about. And I think lots of people, myself included, you want to be able to have the choice, especially if you've been working with doctors and other providers for a long time and you've established relationships. You don't just want to have to move from one to another because your provider isn't in the network.
Absolutely. Absolutely. I think with the Advantage plans, that's really where it comes in. Once you have like a Medicare Advantage, Medicaid Advantage, there they sort of tie all these services in, and there you might end up losing your doctor. I think if it's just MLTC, my understanding is that they can keep their doctors. It really doesn't interfere with whatever Medicare plan they have or anything like that. But she could certainly double check that with NILAG, but I do believe that it should not have an impact on their providers through just a general MLTC program. And then I see in the chat, oh, thank you. Yes. Okay. Oh, so Manling Tam, can you use family members as caregivers under NHTD? So unfortunately, under NHTD, they do not have a provision to provide, to allow for family members to provide the care, and it would have to be done through an agency, a home care agency. So that is another important thing to keep in mind. You know, that there are those limitations with the NHTD program. And then wait, okay, great. And I'm just looking to see if there are any other questions. It's actually, as I mentioned, it's an overview. It's probably going to be more brief than usual, but you know, I'm glad to. The idea was just that people have an idea of what the lay of the land is. I don't know how clear it is to people in the field, you know, on what is out there. So we really wanted to get that out. I also do want to mention, just for everybody's sake, the services that CaringKind provides. So for caregivers, we have our helpline, which is basically our gateway to all of our programs. The number is 646-744-2900. They're really great for information and referrals. You just need to, you know, get information about doctors or about home care agencies or other programs for people with dementia. You know, that we do have, you know, resource lists that they can provide some information from. If you or people you know, would like to speak with a social worker, we do provide social work services. Our social workers provide care planning meetings where we can sort of like help figure out home care. That's, I mean, I do a lot of that, you know, just trying to figure out what the options are for that person. You know, what is the best plan of action given that person's needs. We help with we just actually are starting a new program called Caregiver Coaching, where it's a one-on-one program for caregivers, really focusing on, you know, dealing with the emotional aspects of caregiving, as well as, you know, dealing with challenging behaviors. So, and that's actually, we're going to be launching it with a program called REACH, which is an evidence-based program for the, you know, for the caregiver. So we're going to be starting with that. We have support groups. Our support groups are based in all 5 boroughs. I mean, right now they're all on Zoom, but they will be in all 5 boroughs eventually. So we're, you know, our support groups are kind of unique in that they're closed groups and they meet twice a month. They do require some degree of commitment. They're not drop-in groups, but it can be very powerful for caregivers to be able to just be in a group with that person. It is their time to just be able to share and, you know, I guess, deal with the emotional aspects of their experience with other like-minded people, with a trained facilitator. So if that's something of interest, you know, definitely, you know, that's also through the helpline. You can give us a call. Education and training. This is an example of one of our education programs. We do a monthly education meeting every second Monday of the month. I believe next month's meeting is about activities to do with people with dementia. I actually facilitated Understanding Dementia workshop, which is sort of like Dementia 101 for family caregivers. We have much more deeper training programs. We have a 4-part family caregiver workshop where family caregivers can come. They really are talking about how to deal with those challenging behaviors and how to also balance all of the challenges that come with dementia caregiving and also their own self-care, because that's really, really important. And we really do want to keep highlighting that as an issue and a very important issue for our caregivers. We have, as I mentioned, dementia care training workshops for healthcare, for home health aides. And that is a 6-week program those 2 programs, I believe, are offered in several languages. We have English, Spanish, and Chinese. We have another really exciting program that has come that we just started is our early stage services program. We actually just started doing something called cognitive stimulation therapy, and that is for people in the early stage. It is an evidence-based program based out of the UK. It has been shown to increase scores in cognition and in overall well-being. We just finished our first cohort of the group. It's a 14 session, it's 7 weeks and it's 2 sessions a week. So it's 14 sessions. Actually, it's really 16 sessions because we have an intro session and a closing session, but the actual intervention is a 14-week session. And we just finished our first round of it. And I happened to have facilitated. It was a very, very powerful experience. The people who participated really enjoyed it and really found a lot of benefit out of it. And we are, hopefully we are going to be expanding our offerings for people in the early stage. We're going to be having some meetups and, other things just to keep them being able to socialize and be able to get the support from others who are going through the exact same thing. So we have a medical alert wanderer safety program. And this is actually another thing that you can, on top of referring to this program, social work, another thing I should mention that a person can talk to, the social work is around wandering prevention. We do provide consultation around that. The wanderer safety program is actually with medical alert. The program there's for a fee, a small fee. There's a bracelet, a medical alert bracelet. It has engraved in it, cognitive impairment. It has a tracking number and it has the medical alert number. So this way, if somebody were to wander, a good Samaritan will see that they have the bracelet. They'll take a look. They'll be able to connect that person with medical alert, who will be able to connect that person with their family. It reduces wandering time significantly, which is really important because the first 24 hours are really crucial for a good outcome when somebody wanders. So, that's really important. What's good about our program as well is that we have social work follow-up to sort of also help with figuring out a plan of how can we prevent, wandering from happening in the future, and providing the support that families might need when dealing with this type of behavior. And lastly, and I mean, this is, in my opinion, our most fun program is Connect to Culture. And Connect to Culture is a program that we have. We partner with different cultural institutions throughout New York City. We have a whole bunch of museum tours that we do that are dementia friendly. We're actually having this Thursday, the Orpheus Chamber Orchestra is going to have some players come, and they're going to be playing for our families. And if anybody knows of families that might be interested, of a caregiver and, person who has dementia, feel free to let them know, but it's going to be this Thursday at 2:00. But we do other programs. Some things are dance, sometimes it's art, music, all sorts of artistic kind of things. So that's what I have for the CaringKind stuff. I do have more slides. I just see I have some things in the chat. More information about early stages. Okay, Marcy, let's be in touch, because I see you're interested in more information. And I see somebody asked another good question about workshops on most forms. That's a good question. As far as I know, I don't have that workshop available on my roster right now, or we don't, I should say. That is something that I will bring back to our administration, because that's an important discussion. You might be able to get some information from our legal and financial seminar, which I'm going to be giving information for in my last slide, or might be the next slide. And that you might be able to ask questions about the most there, because it is covering, our legal and financial workshop covers both documentation and Medicaid application stuff. But if in terms of end of life stuff and just as it's standalone workshop, we do not have at the moment, but I can see if we can get somebody to come and speak on that. Okay. Yes, end of life choices. New York is a fine resource for workshops. Okay, good. So yeah. Okay. So yeah, so that's an important discussion. So I will definitely bring that back, and we'll see what we can do on that. So in terms of our upcoming events, so as I mentioned so many times, this is an overview of our home care. If you need a deeper dive in terms of the legal and financial things to know about when it comes to Medicaid, the legal and financial is sort of our 101, and the Medicaid home care seminar is our 102. Legal and financial is a prerequisite to take the Medicaid home care seminar, but through this series, I guess you could call it, it's really going to be going through the entire process of how to go about applying for Medicaid, getting all of the documentation needed, and things to know. So just for you to be aware, our next legal and financial seminar, and all of these seminars are virtual. I should have put the Medicaid home care as virtual as well. So it's going to be, the next one's going to be on Monday, June 27th from 5:30 to 7. The one after that will be in August, on August 15th, also from 5:30 to 7. And then again, after you take that one, you can take the Medicaid home care seminar. And we have 3 dates for that one, and that's going to be July 7th. Also, there's 5:30 to 7:30. Thursday, August 4th, 5:30 to 7:30, and Thursday, September 1st, from 5:30 to 7:30. I will mention though, you know, in terms of most, in terms of any questions around powers of attorneys, healthcare proxies, living wills, I'm not sure about wills, and maybe some will stuff. Our legal and financial seminar kind of provides an overview of those materials as well. So if you do have questions around documentation for, you know, healthcare provision of any sort, I would say it's probably worthwhile to join that one. And so here's resources, as I mentioned, I was going to be providing. So the number for ICANN, I have their website, and this will all be sent to you. I'll make sure that we send that to you. I have, so New York Connects is the number for Department for the Aging. They kind of network you with your local offices and services in your particular area and district. And I also put down the NHTD regional offices, again, just in case, you know, you wanted that information on hand. And with that, that's the end of my presentation. I'm open to any more questions or comments. If there's anything that needs clarification or any other burning questions, I'm eager to hear. Hi. And I see Dallas. Hi. I know you. No? Okay. So if not, then I want to thank everybody for coming, and you know, have a good night. And if there's anything, you know, anything we can help you with, please feel free to call our helpline. We're happy.
Thank you, Dina. This is Dallas from Heights and Hills.
Oh, hi, Dallas. How are you?
I'm good. Just want to say thank you for the training.
Sure. Thank you for coming.
Okay.
Okay. Thank you, everyone. Have a good night.
Good night.